The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to Your Health, Your Choice. Tonight it's Wednesday, the 4th of September, 2019. Giving you the date because we've been away for a while, August holidays, and there were several replays of our programs we've done in the past. So we are live tonight. So how these programs work, Your Health, Your Choice, we every 2 weeks or so we do a live program. And my wife and myself, usually, we're here together, but Linda's not here to light up the program, so you'll have to do with me tonight. But in 2 weeks' time, she should be back. We call the program Your Health, Your Choice, because your health is indeed your choice. Very often, in fact, just today, I was saying to one or two patients, fairly young diabetics, that they have such a number of years ahead of them. And if they did not make wise choices, they could see severe complications of diabetes. Of course, we're going to revisit some of the basic concepts of diabetes tonight. And in 2 weeks' time, we will do something called, hopefully, the pathogenesis of type 2 diabetes, where we look at some of the underlying causes for diabetes. But tonight, I'm going to revisit some of the basics of diabetes, because so often I find myself having to go over some of those basic concepts with patients and family members. So we're going to do the program a little bit differently tonight. We're going to take calls earlier on after the first break. So the telephone number will come up after the first break, but you can write down the number now. It's 652-4855. And the calls do not tonight have to be on diabetes. I'm willing to, my basic training was as a family physician, and then diabetes as a subspecialty. And although I do mainly diabetes now, which is diabetes, hypertension, hyperlipidemia, prevention of cardiovascular disease, etc., I'm willing to at least try and answer some of your general questions. So if you're looking at this program on a Thursday, usually at 1 p.m. it's played, or on a Sunday night, of course, you can't call in. So you have the opportunity to call in tonight. So it's 652-4855. And you can start WhatsApping some of your questions. If I get questions before the first break or just after the break, I'll try and answer some of those questions. And the WhatsApp number is 360-0105, 360-0105. So coming back to the basics of diabetes, it's essential that we understand what diabetes is all about. And very often people reduce diabetes to some basic things that when I talk to patients or even family members, I realize that there's a real misunderstanding about some of the basic foundational principles of diabetes. So I want to bring up slide 2 on our PowerPoint slide kit. And this is a slide that we have showed before, that diabetes is common, it's chronic, but it's controllable. So I want to repeat that. It's common, it's chronic, but it's controllable. And some of the figures you see there on the left-hand hand of the slide is more American figures. It affects 1 in every 13 people. In Trinidad, it's more like 1 in 7. Or 1 in 8, about 15% of the population. And it's a lifelong condition, and good management depends on you. So we can just come off that slide for a minute. So I just want to repeat those 3 C's, I call it, of diabetes. Now, you might see me a little bit distracted looking at the iPad, and I have 2 iPads in front of me. Usually when Linda's with me, she's asking the questions. But I'm going to go through the slides, but I'm going to keep my eye out if anybody sends in questions before the first break. The number for that, for the WhatsApp, is 360-0105. So we are saying that diabetes is common. It's extremely common, and more so type 2 diabetes, of course. Of all the patients that have diabetes, about 95% of patients, 95% of patients will have type 2 diabetes, and maybe only about 5% will have type 1. And in Trinidad, our prevalence of diabetes is somewhere between 13 to 15% of the population. So that works out, what, about 1 in 7 to 1 in 8 of the population. And another 30 to 40% might be pre-diabetic. So we talk about pre-diabetes, and that's a very common concept. But before I come to that concept of pre-diabetes, I just want to give you those two other C's. So it's common, it's chronic. What do I mean by chronic? We have different types of medical conditions. So some conditions are chronic, some conditions are acute. If you have a throat infection or chest infection, that can be termed an acute illness. Very often you can be given antibiotics, and you might have that illness for a few days, maybe a week, and then it's gone. You're cured. But diabetes is a chronic condition. So very often patients ask me, is there a cure for diabetes? Doc, I don't want to take these tablets for the rest of my life. Or, doctor, if you put me on tablets, does that mean I'm going to become dependent on tablets? So that's a common question we are often asked. So if I go into insulin, as many people desperately need insulin, and I want to just say that there's a lot of misconceptions about insulin therapy. Insulin, of course, is one of the most important treatments for a lot of diabetics. Not all diabetics will need insulin, but a lot of diabetics do need insulin. And unfortunately, insulin therapy is often delayed for sometimes 3-4 years. So diabetes, it's chronic. It's with you for life. But the good news is the last C. It's controllable. But the control really depends upon you, how well you are willing, and that's on the right-hand side. Good management depends on you. So you can be well controlled as a diabetic and live a normal life. You can have a normal lifespan. You know, we have diabetics, have been diagnosed 30, 40 years ago and have very few complications of diabetes. As opposed to that, we have many patients with diabetes just for maybe 5 or 10 years, or they think they have had it for 5 or 10 years, and they've already developed severe complications of diabetes. So diabetes is common, it's chronic, but it's controllable. But the control does depend upon you. So if you get those basic concepts right, you will understand the way we manage diabetes. I want to go on to slide 14. On slide 14, we look at the types of diabetes, because that's another common issue that often comes up. So the first type of diabetes we are talking about here is type 1 diabetes. Now, this used to be called insulin-dependent or juvenile diabetes. And the body basically destroys the beta cell. Remember, the beta cells are the cells in the pancreas that produces insulin, so they can no longer produce insulin. These patients need daily injections of insulin, and most often its onset is in children or young adults, but only about 5 to 10% of those people will have diabetes. So I just want to dwell on that for a minute or two, because again, one of the common misconceptions is that if an adult comes in with diabetes, it has to be type 2 diabetes. But we do know that there's a latent onset or a later onset of type 2 diabetes, of type 1 diabetes, where a patient may present very slim, very lean, losing weight, excessive thirst, etc. And the red flag should go up in that kind of patient to know whether it's a type 1 patient or a type 2. So most times when young kids come in, it's type 1. But on the other side of that is that we do see some teenagers with type 2 diabetes. And these are particularly those patients who are quite overweight, strong family history of diabetes. So how do we differentiate between type 1 and type 2 diabetes? So there are some blood tests, additional blood tests, apart from the basic HbA1c and kidney function, liver function. There's something called a C-peptide levels that can be done, and that blood test can be done locally. Most of the labs can do that, and that can give you an idea of how much insulin the beta cells are producing. And I personally like to do the 2-hour postprandial, the 2-hour postprandial or 2-hour after meal C-peptide levels, because that gives you an idea of how the beta cells are responding to a carbohydrate intake. But you can also do something called GAD antibodies, GAD. I'm not going to go into the long meaning of that, that acrostic, but it's called GAD antibodies. And if the patient is GAD antibody positive, it means that antibodies are destroying the beta cells. And of course, you can do islet cell antibodies. People often ask for measurement of insulin levels. Well, it's very difficult and very expensive to do insulin levels, and it's notably very difficult, not the most accurate measurement. So to differentiate between whether a patient, if you have doubts whether a patient is type 1 or type 2, then you can do C-peptide levels, you can do GAD antibodies, and that will clarify. Now, one proviso here is that over the last few years, I've seen a few patients, and by the way, the WhatsApp number has come up again, 3600105. Some people don't like to, might be a little bit shy, don't want to call in. So, and as I reminded you, you can WhatsApp questions, not just on Diabetes Tonight, on a wider range of issues if you would like to do that, because I'm giving you the opportunity, as it's the first live program for a while. If you would like to call in, it's really a community service that we offer on this program. So type 1 diabetes, more in young kids than older adults, but some older adults can also present with type 1 diabetes. What about type 2 diabetes? So slide 15, type 2 diabetes shows the little difference between type 1 and type 2. So in type 2 diabetes, the pancreas is no longer able to meet the demand. It's no longer able to meet the demand for insulin, and the body can no longer use insulin properly. So there are two concepts there. The pancreas no longer is able to meet the demand for insulin. It's producing insulin, but not enough, and the body can no longer use insulin properly. And it's most often seen in adults, and increasing rates of childhood obesity, causing growth of the number of people with type 2 diabetes in children and young adults. And this accounts for almost 90% of the cases. So we can just come off that slide for a minute. So type 2 diabetes is what we deal with most of the day if you're dealing with diabetics like I do, and in our chronic disease clinics, etc. Type 1 diabetics are often more referred to the tertiary centers, but in my clinic, the clinics I used to do with the Southwest Regional Health Authority, I'm no longer with the Southwest, we used to see a lot of type 1s because those were specialist clinics we had set up in the community. So type 2 diabetes comes on, and the point I was going to make about type 1 is that sometimes we see people with type 1, and in the early stages, the pancreas is still producing some insulin, and we could be lulled into a state of comfort, thinking we can manage those patients on tablets. That's why if you do the C-peptide levels and GAD antibodies, and the patient does show up to be positive for those, then you would put that patient on insulin. And very often in type 1 diabetes, we have patients not needing a lot of insulin. So I have a question. This is an interesting question, so thank you for this question tonight. Somebody has WhatsApp a question. Good night. Please explain what is ketoacidosis. Now, that is a very, very good question that you have asked. Ketoacidosis is a condition that presents in type 1 diabetes. And it's a condition where, because the body is not producing insulin, the body begins, if you do not get insulin in a timely manner, the body begins to produce lots of ketones, and ketones accumulate in the bloodstream, and you can become, get into a state of acidosis, which is an extremely dangerous condition. It's life-threatening, and that's why type 1 diabetes was, always considered to be the more serious condition than type 2, but because we have got better at giving insulin therapy, we have better ways of giving insulin, the rates of ketoacidosis have fallen over the years, and we have better access to insulin in Trinidad, fortunately. So we still see conditions of ketoacidosis, and one of the common reasons for patients going into ketoacidosis, either they're diagnosed late on, and they've been started on tablets when they really needed insulin. So that's why I'm saying, when you see a patient coming in with drastic weight loss, excessive thirst, passing lots of urine, although that can be type 2, the red flag should really go up. That could be a type 1 diabetic you're dealing with. And if they're not given insulin, and sometimes type 1s, they're on insulin, but they might be sick for some reason, vomiting, diarrhea, and the patient thinks that, okay, I'm not eating, so I'm going to stop my insulin. What you have to remember is that even if you are ill and you're a type 1 diabetic, you might be surprised you're not eating and drinking very much, but your blood sugars are still 400s and 500s, and you're spilling a lot of ketones in the urine, and you can still go into ketoacidosis. So recently I saw a patient a young man, just about 17 years old, and when he came to the office, his blood sugars were above 400 to 500, and he was very drowsy, his pulse was racing, and immediately the red flags went up, and I admitted him to hospital immediately, and he was in ketoacidosis. So it's a good question, and it's something that we have to be on the lookout for. So type 2 diabetes comes on more in later life, and it's often due to a strong family history. So the patient may have a strong family history, might be overweight, although not all type 2 diabetics are overweight, so don't get misled by that. Very often I see people in their 20s and 30s who are fairly slim and lean, but because of the strong family history, they develop type 2 diabetes. Well, time has gone very quickly. I see we are going to our first break. So we'll go to our first break, and when we come back, we will open up the telephone lines, and we'll continue to take the WhatsApp questions, and we'll continue to talk about diabetes. We go to our first break tonight on Your Health, Your Choice.
Looking for a safe place for the whole family? Well, now you've found it. We are ACTN The Voice, your family-friendly station. Whether it's current affairs, kids and classic TV, sport and community features, Christian and music programming, plus so much more, ACTN is the station for you. Join us each day for programming that puts morals, values, and family first. We are ACTN The Voice, your family-friendly station.
You're watching ACTN, The Voice. ACTN The Voice, your family-friendly station.
Hi, I'm Becca Shea, and you're watching ACTN The Voice.
Well, welcome back to Your Health, Your Choice. It's Wednesday, the 4th of September. We have not been live for a while. We were doing lots of replays during the month of August, but we're live tonight, and you can WhatsApp your questions. I have a second question I'm about to answer, 3600105. Or you can ring in now on 6524855. As I've said, because we haven't had a live program, you can ask questions, not necessarily just on diabetes, on any other questions. And during the week, you can ring on 482-4269. Now, I try to return the questions that are asked, but I may not always get around to doing it, but still try and send in your questions on 482-4269, and that's also the number for the various services that are offered, medical services, and information about the Anaposis Chapel as well. 482-4269. Can I just say at the start of this second segment, which I was supposed to begin with, our thoughts and prayers are with the people of Bahamas, unfortunately hit by extremely powerful hurricane. And there are various organizations that are trying to raise funds and send supplies. You'd see it advertised on Facebook, newspapers, etc. The one that I would mention is an organization called Is There Not a Cause? Is There Not a Cause? Avanel Hector. She's well known in Christian circles. I just want to encourage you, if you want to find out more, you can ring us on 482-4269 and we'll give you her contact numbers. She has been involved in various outreach projects by other nations like Haiti when they were hit by a powerful hurricane. So is there not a cause? So if you're interested, and you know, the people of Bahamas, prayers are good and important, but the Bible says faith without works is dead. So it's not enough to pray. Now is the time to reach out with hearts and hands of compassion. It might be financial, it might be other basic goods and services that can be offered. So please try and help the people of Bahamas. So I have another question here on the WhatsApp. It says, good night, I'm type 1 diabetic, and I feel burning sensation going through all my body. What could that be? Now, the burning sensation has to do with the nerve ends. I'm not sure how long you have been a type 1 diabetic, but if you've been a diabetic for more than 10 years, very often you can get a form of neuropathy. Now, the typical diabetic neuropathy often affects the feet. So I have patients every single day coming in with burning in the feet and burning, pricking sensations, and that's typical peripheral diabetic neuropathy. But there are different forms of neuropathy, and some people can get gastroparesis, where they get bloating after eating small meals. Some people can get a diabetic neuropathy affecting the heart, where you can get arrhythmias. The burning all over the body is a symptom I've seen a few patients with, and it could be diabetic neuropathy. I'm saying, of course, I've not seen you personally, but you can go to your physician, talk about it. If it is diabetic neuropathy, there are different medications that can be used. Now, I know when we talk about medication, people are often, sorry, I'm just bringing up another question. When we talk about medications, people often think, well, am I going to become dependent on these tablets? Well, you know, there are tablets like Lyrica, gabapentin, Cymbalta. I often start with a natural supplement called alpha-lipoic acid, which may help people. It's an antioxidant, vitamin B12. But it sounds like neuropathy, and it's one of the complications of type 2 diabetes. I have another question here, so I'm going for the questions tonight because we're going to be coming back with live programs where we'll cover a lot of the information. Good evening, doctor. Great job. Thanks for all the information you have been disseminating. What causes the blood sugar not to be at a consistent level at fasting? My level used to be 109, 115 at most times. It's 145 now, 151. I'm on 2 metformins morning and evening, 1 Deonil on mornings, half an hour before breakfast. I'm a type 2 diabetic. So very, very good question. Very, very good question. I see this all the time. You know, type 2 diabetics have been well controlled for years. Their blood sugars have been 100, 110, 115. The blood tests that we often do that gives us a more long-term picture of your diabetes is called the HbA1c. So please remember that term. You must ask your physicians or your diabetes educators, whoever you're seeing. You should do a HbA1c at least twice a year. Now, unfortunately, I'm still hearing, although I'm no longer, as I said, with the Southwest Regional Health Authority, some health authorities still do not have that basic blood test. Can I just say, and maybe I can, well, even when I was with the Southwest, I spoke very clearly. It's impossible to manage diabetics properly without proper lab testing. You just can't do it. You know, as doctors, as healthcare professionals, we've been asked to see patients, and that's why when patients come to me, some patients may find that I do a lot of blood testing, but if you follow the guidelines from the American Diabetic Association and the EASD, which is the American Association for the Study of Diabetes, A1Cs should be done at least twice a year. And if you're not well controlled, about 4 times a year, every 3 months. Those are the guidelines. Yet we struggle to get a basic A1C done in some of the health authorities. And we're trying to manage diabetes. So I'll say again to the Minister of Health and the Ministry of Health and the regional health authorities that diabetes is one of the most common conditions that we deal with as healthcare professionals. And if we do not know that, you cannot manage a diabetic patient. I get animated and passionate about this, but you cannot manage a diabetic patient by purely looking at a fasting blood sugar or just a few blood sugar readings. You need the A1C, or even what we have now is continuous glucose monitoring, CGMs, something called the Freestyle Libre or the iPro 2 device. So the question to this, answer to this question is, diabetes is a progressive condition. So although your blood sugars may have been at 110 or 115, what you have to understand, and even today I was trying to explain to a few patients and relatives that it's not always the patient's fault. You know, very often patients come in, and especially I see sometimes parents, you know, as people get older, the parent becomes a child and the child becomes the parent. The child might be, a young adult, and they're kind of accusing the parent of eating badly, having too much desserts, etc. Listen, diabetes is not meant to, having diabetes is not meant to be a punishment. You know, quality of life, I'm being philosophical, I'm waxing philosophical tonight. Quality of life is as important as quantity. Yes, we want diabetics to live a nice, long, healthy life. But, and I'm not saying for a minute that you should eat badly, but healthy eating means a balanced diet. And there's no reason why people can't have an occasional dessert, etc. If you can't even have a small dessert and your blood sugars are going to 300 to 400, that simply says that your pancreas is not producing much insulin. So, you know, you could try and starve yourself and your blood sugars will stay high, and you get frustrated. There's often the accusations flying back and forth, and people become depressed about their diabetes. So the answer to coming back to this question is the reason why your blood sugars are probably going up is, one, your pancreas is not producing as much insulin as it did a few years ago, and two, there's something called the dawn phenomena. In the early hours of the morning, the liver begins to spill sugar out. That's called gluconeogenesis. Glucose is broken down into the bloodstream from stores in the liver, and you get a higher blood sugar on a morning sometimes compared to the blood sugar you went to bed with. And again, people are confused by that. How come I have a higher blood sugar on a morning when I went to bed with a blood sugar of 110 or 120? That's something called the dawn phenomena, and there are good medications available for that. Now, this particular patient, you're just taking metformin and Deonil. I have to say, those are two very basic tablets. And although they are available on CDAC, really, we have lots of newer medications. In fact, Deonil is almost outdated now, and I probably have none of my patients on Deonil. There are tablets like the DPP-4 inhibitors, Januvia, Galvus, Tradjenta, etc., Combiglise. There's now the new group of tablets called the SGLT2 inhibitors, Jardiance, Forxiga, Invokana. And in fact, if you look at the American Association for Clinical Endocrinology, their guidelines, sulfonylureas, which is like Deonil, glycoside, have been relegated very low down on the list after metformin. So there's a lot of scope for intervention in your case, and I think you should visit your doctor and talk about some of the newer medications, do your A1C, and be screened for the complications of diabetes. I know we're not covering some of the slides I wanted to cover. Can I just say that when I talked about type 2 diabetes, it's often driven by family history, but of course it's often driven by poor lifestyle. So people tend to put on weight as you get into your late 20s, your 30s, especially weight around the tummy area, what is called abdominal adiposity. So a lot of patients put on weight around the tummy area, and adipose tissue releases enzymes like leptin and interleukin and fat tissue in the tummy area is not just inert fat. It's actually considered an endocrine organ, and it's releasing enzymes that can cause insulin resistance and can cause the body to require intervention and bring on type 2 diabetes. Now, I just want to say something. I have another question here, but I just want to make the point that people are beginning to do things like liposuction and trying to get rid of the belly fat. Now, that's good, but what we are really concerned about in type 2 diabetes is visceral fat. So what do I mean by visceral fat? I'm talking about fat around the organs. So if you do an MRI scan or a CT scan, you often see a fatty liver or fat around the pancreas. And very often, if people were to lose about 15 to 20% of their body weight, there's good literature, good science to say that if the fat is relieved from around those organs or within the liver, the beta cells can kick back in. So there can be a bit of, I would not say a cure for diabetes, but you can see a remission to a certain extent in the early stages of type 2 diabetes, where the beta cells can kick back in if you're very overweight and you lose about 15 to 20% of your body weight. I'll probably come back to that. I just want to remind you, you can also, WhatsApp questions are coming in, but you can also call in on 652-4855, 652-4855. I have another question here. Good evening, doctor. Can you say the duration of prediabetes? Okay, another very good question. We're getting some good questions tonight. So prediabetes is something that we have become more concerned with because from the pre-diabetic state, people become at risk of cardiovascular disease. And we can even see some microvascular complications of diabetes setting in from the pre-diabetic state. And that's a little bit surprising, but it's well documented in the literature. I can't give you an exact timeline, but we know that pre-diabetic, people who become diabetic, if you could reverse the clock and they were doing blood sugars up to 10 years before, they would have seen their fasting blood sugars begin to rise slowly, and then the 2-hour after meal readings. In fact, the first reading that begins to go up in the pre-diabetic state is actually the 2-hour after meal readings. And of course, unfortunately, very few people, even diabetics, do 2-hour after meal readings. Most people just do their first blood sugar reading in the morning. And that's why just doing a fasting blood sugar reading is so deceptive, because I had a patient this morning, had a fasting blood sugar of 130 or 140, but had a roti to eat, I think, if I remember correctly, before coming into me. And when I did the blood sugar 2 hours after, it was 400 and something. 400, yes, over 400. And the patient was shocked by that. How come the fasting blood sugar was so good and the 2-hour after meal? But what that shows is that the beta cells could not cope with the meal, And although you may say, well, if that patient didn't have that roti, the blood sugar wouldn't have gone up. But if that patient was not diabetic, the blood sugar would not have gone up to 300 to 400. The beta cells would have kicked back in and produce rapid insulin to bring the blood sugars back down to normal. So the pre-diabetic phase could be up to 5 to 10 years before the patient becomes diabetic. So I am now beginning to see patients, because we have been talking on this program a lot about pre-diabetes. I'm seeing people coming in asking to be tested for pre-diabetes. And that's, very heartening, because people are becoming more aware of their risk of diabetes. And when we do the what is called the glucose tolerance test, what we see is that the fasting level might be good, but the 1 hour value might be over 200, and the 2 hour value might be between 140 to 200. And if your fasting level, if you do a proper fast overnight, and your fasting blood sugar in the morning is above 100, between 100 to 126, that's defined as prediabetes. And if your 2 hour after meal, well, after the glucose tolerance test, is between 140 to 200, that's also defined as prediabetes. Slide 16, I just wanted to mention gestational diabetes. And of course, gestational diabetes is diabetes. It's a temporary condition during pregnancy. It occurs in between 3 to 4% of all pregnancies. And of course, it increases the risk for developing other types of diabetes later on in life for both mother and child. So gestational diabetes is something that we screen for, and very often, in fact, sometimes patients may not know that they were diabetic, and they come into pregnancy, and then we pick up diabetes and we call it gestational diabetes. So we just have to be aware of that. But what happens in pregnancy is that it's a state of insulin resistance. And most times, people who develop gestational diabetes would have had a family history of diabetes. If you have a strong family history of diabetes, and you're a little bit overweight, you come into pregnancy, you really should be screened for gestational diabetes. And of course, a lot of people would have to go on metformin or insulin therapy in a pregnancy to manage the pregnancy. And the diabetes may clear up after pregnancy, but please remember, once you have had gestational diabetes, you have a high risk, about a 50% risk of getting diabetes later on in life. Well, we're going to go to our second and final break on Your Health, Your Choice. Thank you for all the questions that have been coming in. When we come back, I want to encourage you to keep sending in your questions and call in on 652-4855. So we go to our second break tonight on Your Health, Your Choice.
You're watching ACTN, The Voice. ACTN The Voice, your family-friendly station.
Hey, listen, we have some great news for you, our loyal viewers. No, we love to interact with you on a daily basis. So, sometimes do it via telephone, otherwise Facebook. But now we've added our new WhatsApp phone number. That's right. You can now text us live on our various programs right here on ACTN The Voice at 360-0105. That's 360-0105. Send us your comments, send us your questions, and get this, even better, after the lights come off, you can continue sending your comments and your questions, and we'll respond to them the following day. So that's right here on ACTN The Voice, we have now opened up more mediums for you to interact with us. Facebook, telephone call, and now you can WhatsApp your comments and questions right here on ACTN The Voice.
What's up, y'all? This the Kid Flame.
This is Spec. This is Mike Real.
And you watching ACTN, The Voice. Keep it locked.
Let's talk about it. Your boy's been a Christian quite a few years. Victory and faith, but I failed in my fears. I heard a lot of words that have tickled many ears. That's why I praise God for the word that we adhere. The word became flesh, lived for 30 years.
Welcome back to Your Health, Your Choice. That was quite a nice advert from Sheldon. I want to congratulate him, reminding us of the telephone numbers, 6524855, and the WhatsApp number 3600105. And we've already had several questions tonight. And just kind of summarizing some of the basic concepts of diabetes, seeing that we've been away for a while, although we had replays. So you can also WhatsApp your questions outside of the program on 482-4269, and that's also the number to get more information about the Anaposis Medical Center, as well as the Anaposis Chapel, the church that we lead in Coquille. I just want to mention there's a really crisis in Bahamas, and people need help desperately. I know lots of people are praying. But as I said, prayer is wonderful, but this is a time for action. And there are various organizations that are advertising to send in funds or non-perishable items. But the one I just want to mention is There Not a Cause, led by Avenel Hector. And if you need information, you can ring the station. They may have the contact, but we also have the contact on 482-4269. So we have only about 15 more minutes, so don't lose the opportunity to WhatsApp your questions in or call on the numbers that are there on the screen. We've been talking about some of the problems associated with prediabetes and how we can identify people who are prediabetic. And remember, it's in a prediabetic phase that we could probably turn the clock back. And so that's that question that came in. It's an important question because people come in after 5 or 10 years of diabetes, and then they're asking whether there is a possibility of a cure for diabetes. But the time to really intervene and try and turn back the clock is in the pre-diabetic phase. Because in the pre-diabetic phase, the insulin, the pancreas is still functioning. It's not functioning optimally. Insulin resistance is rising. So if you look at some of the diagrams, graphs we show, especially when we're doing lectures to colleagues, we show that insulin resistance, and insulin resistance has to do with very often a sedentary lifestyle, poor eating, and putting on weight. So if you can intervene in the pre-diabetic state, then at that stage, you can turn the clock back, and the diabetes may actually go into complete remission as compared to 10 years into diabetes, even if you were very overweight. So, the thing about this is, gastric bypass surgery is becoming more and more popular and common in patients with BMIs above 28 to 30. It's not available on the government service. It's available in the private sector. And I have had quite a few patients who have done gastric bypass surgery, but the remission rates are different. So even with gastric bypass surgery, the evidence, the data that's available shows that the earlier you do gastric bypass surgery in the history of diabetes, the higher the rates of remission. So the later on, the diabetes may go, but it can come back. And I've seen that in several patients, that the diabetes disappeared or went into remission, which is the word I try to use. And then 5 years later, patients turn back up, and they've not always put back on weight, but the diabetes have come back. I think we have a call. Good night. Welcome to Your Health, Your Choice. Good evening. Hello? Good evening.
Good evening. Yes, I'd like to find out. I'm a diabetic now for 20 years. and I've managed it relatively well because I cook my own food and all that. My main problem now, I find, is that I'm always hungry, and I was wondering if I'm hungry because I'm diabetic for 20 years. I take one diamicron and 2 glucophage twice a day, nothing at lunchtime.
Right.
I try to exercise and all that. Right.
So that's an excellent question, because I have to address this in patients quite often, that this hunger that patients often experience with diabetes. And again, patients are often accused by relatives of being greedy and, wanting to eat too much, etc. But actually, and in 2 weeks' time, we're going to talk about something called the ominous octet. The ominous octet is a big term for the 8 pathological defects in type 2 diabetes. 8 factors. So diabetes doesn't have just to do with poor lifestyle and eating badly. It actually, there are 8 pathological defects. And one of the defects is a neurotransmitter dysfunction in the brain. And the hippocampal area of the brain is changed. And people with diabetes actually do experience increased hunger. So what you're experiencing is very often part of diabetes. Now, some of the medications we use can often exacerbate that. So people on insulin often find that they experience increased hunger. So insulin is an appetite stimulant, but those who need insulin, but we have to be cautious that we advise and counsel patients when they're taking insulin about the possibility of weight gain, etc. And that's why, so you're taking, for example, Daonil, I think you said also, or diamicron. So the sulfonylureas can, the sulfonylureas stimulate the pancreas directly, which means that you're producing more insulin. And of course, insulin is an appetite suppressant. My choice very often, I'm not saying sulfonylureas don't have a role, don't get me wrong, but I very often would go for a DPP-4 inhibitor or one of the new drugs, the SGLT2 inhibitors. The problem with that is that they're more expensive drugs, and if you don't have the resources, you very often have to stick with the CDAP drugs, which are very limited. I have to say CDAP is, the CDAP forms that we have, basically there's metformin and glycoside, that's it, and insulin, and even not the newer types of insulins. So we are trying to manage diabetes with limited resources. We have another call. Thank you for calling in on 652-4855, 652-4855. Good night, good evening. Welcome to Your Health, Your Choice. Good evening. Hello? Good evening. Okay. Hello? Please hang up. Okay, so I think we lost. We have lost that call. You still have about 10 minutes, so you can try ringing back on 652-4855 or what's upping the question. I think there might be another question. No. So I want to bring up slide 18. I know I'm working Josh hard tonight because he's answering the telephone lines as well as trying to bring up the slides. Thanks, Josh. You're doing a fantastic job. So the risk factors, and this is one of the slides I wanted to spend a few minutes on, because if you have some of these risk factors for type 2 diabetes, it's important to be on the lookout. So if you're age 40 and older, that's a risk factor for diabetes. A member of a high-risk ethnic group. So this is an international slide. So Aboriginal, Hispanic, Asian, South Asian, African descent. Okay, we have a call coming in, so I'll come back to this slide. Good night. Welcome to Your Health, Your Choice. Hello?
Hello?
Yep. Can we have your question?
Yes, Doc. I like to eat plenty. Yes, I do. I like to eat plenty sweet things.
Are you diabetic?
No.
Okay. So the question is, Are you asking whether it's a good thing what you're doing or a bad thing?
Yes, I want to know if it's a good thing or a bad thing.
All right. Okay. Well, you know, the person is saying they like to eat a lot of sweet things. Life is about being moderate. Can I just say that? I don't believe, I don't support what I call draconian diets that some weight loss clinics try to put forward. I don't, in fact, the ketogenic diet, which is very popular on Facebook, etc., it's physiologically unwise. So I'm challenging people who promote the ketogenic diet. Of course, if people go on a ketogenic diet and cut out all carbohydrates, they will lose weight. But how is that sustained in the long term? So I want to say very strongly that ketogenic diets, these rapid weight loss diets, and of course, weight loss clinics become very popular because people see that they lose weight initially. But very often I see patients 6 months down the line and they've put back on the weight. Patients cannot survive without carbohydrates. I want to repeat that. Patients cannot survive without carbohydrates. You need a balanced diet. And again, we will revisit this. So you need some carbs, but the important thing is the type of carbs. So this person who rang in was saying they like a lot of sweet things. Well, you have to be careful about that, because if you're eating lots of chocolates, drinking lots of soft drinks, you may not have diabetes yet, but you could still develop diabetes at an old, as you get older. So I would say to be moderate. I wouldn't tell you to cut out all cakes, etc. But be moderate in what you're doing and have a balanced approach, not just to eating, but to life. So you need to eat healthily, a small amount of carbs, the low glycemic index. So you can, those of you who are use the computers, you can Google low GI foods are better for you. They are absorbed more slowly, and that often equates to high fiber foods. So low GI foods, a small amount of carbs. You can have protein. If you're vegetarian, you need your protein source from some source other than meat. But if you're not vegetarian, white meat, lean meat, fish, chicken, and then, of course, lots of vegetables and salad. And that's a good way of eating. We only have about 5 more minutes, so I'm just going to revisit that slide 18 as we complete tonight. Slide 18. If you're one of the high-risk groups, if you're overweight, especially if the weight is carried around the middle area, the tummy, a parent or sibling with diabetes. So if you have mother and father diabetic, you have about a 90% risk of developing diabetes. If you gave birth to a baby that weighed more than 9 pounds, you may be at risk. That may have been an indication that you had gestational diabetes. Of course, gestational diabetes, impaired glucose tolerance. If you have high blood pressure, high cholesterol, and the ones that are not showing up on the slide, on the screen, polycystic ovaries, acanthosis nigricans, and schizophrenia. So I'll just explain those last 3 as we come off the slide. Polycystic ovaries, a very common diagnosis in young girls, especially polycystic ovaries. Let me just say on that point, a lot of people are diagnosed with polycystic ovaries, but they don't have polycystic ovarian syndrome. So if you have polycystic ovaries, don't panic. You need to do the complete hormonal profile to see if your FSH, LH levels are inverted, and that will tell you whether you have potential problems with fertility, etc. But if you have PCOS, polycystic ovarian syndrome, there is a connection, a risk for type 2 diabetes. Acanthosis nigricans is a dark skin, dark velvety skin around the back of the neck or on the knuckles, on the knees sometimes, and that's a marker for insulin resistance. And schizophrenia, the reason schizophrenia is not the condition itself, but schizophrenics are often placed on drugs that can be diabetogenic. It can cause the blood sugars to go up. So I want to thank you for calling in tonight and for all the questions that came in. And you can still, we have about 3 more minutes, so I can't take any more questions tonight, but you can still send in questions on the WhatsApp number, as Sheldon said on one of the adverts, on 3600105. If the questions come there, the team will send through the questions to us. But you can ring us directly on 482-4269 or WhatsApp us on 482-4269. We are redoing our website. The website is still up, www.anaposiscommunity.com, and that's a website for the medical center, the church, and Lengua Linda, which is run by Linda, my wife. It's this teaching arm, English, Spanish, and something called the English Speaking Board exam. So as I wrap up tonight, I reminded you that tonight we were live, the 4th of September, and the program will be replayed on Thursdays at 1 p.m., Sunday nights at 6:30, and replayed next week, and then we come back with a live program in about 2 weeks' time. Over the last 2 weeks, we were away for most of August, and over the last 2 weeks, as I returned to our church, which is based at 12 Johnson Street in Coquet, we have been talking about divine direction. I guess all of us, at points in our lives, we need direction, divine direction. It might be a job situation. It might be a relationship challenge we are having. It might be financial issues in our lives. So many people are losing jobs and have mortgages to pay. Can I just say, who you are today and where you have arrived has been a result of a series of decisions you have made over a period of time. So you're not who you are today because of your parents, the fault of your parents necessarily, or because of your husband or wife. We often play the blame game, and I often challenge people to take responsibility for who you are. You are, especially as an adult, who you are today is a result of decisions you have made. And one of the things about divine direction is that you can hear from God for your life, but very often you have to still yourself, be still and know that I'm God. That's what God's word says. But one of the things I shared last week Sunday as I end is that surround yourself with people who are wise. There's a proverb that says if you associate yourself with fools, you'll become known as one of them. That's a hard scripture. So if you want to be wise, associate yourself with people who are wise in business, in academics, in church life. Find a good place where you can worship and surround yourself with wise people. People like that can speak into your life. Thank you for joining us tonight on Your Health, Your Choice. As I said, the program is replayed and we come back with a live program in 2 weeks' time. I'm Dr. Claude Khan. Thank you for joining us.